I first read about it, like a lot of people, in the media, but of course I was also at CDC, and I began to hear about from colleagues there shortly after they created the AIDS task force in 1982. I began to hear about this lymphadenopathy syndrome, and I began then to follow some of the investigations that CDC launched in that time.
Were you ever part of the AIDS task force?
I was not part of the AIDS task force, no.
Okay. Now, before HIV was identified as the cause of AIDS, multiple hypotheses were put forward. What was your initial thoughts?
Well, I always thought that it was an infectious disease because of even the earliest patterns of transmission. And in fact, some of the early work in my laboratory, because even though I wasn't part of the AIDS task force, we actually were involved in some of the early efforts to look for an etiology, because I was running the hemorrhagic fever laboratory, the high security level 4 laboratory at CDC. So we pitched in with, like a lot of laboratories did at CDC, to try to look at, to see if we could see what the etiology might be. And I think most of us at that time were fairly convinced it was an infectious agent, probably a virus, because it was so difficult to identify.
And when did you first hear about AIDS in Africa?
That was in 1983, and I was at a meeting, it was in June, and I was a meeting of viral hemorrhagic fevers. And there was a colleague there who told me about these cases of lymphadenopathy syndrome, or as it was already starting to develop, the acquired immunodeficiency syndrome, since people had started to identify the fact that they seemed to have a certain type of immunodeficiency. He told me they began to see a group of these patients in Belgium, and they were coming from the Democratic Republic of the Congo. And because I'd been a school teacher in the Democratic Republic of the Congo and knew it well, I said to myself, there's no way that the average person could ever get on an airplane and go to Belgium to get treated for any kind of disease. And so if they're seeing these kinds of people, that is, people coming for this treatment, there must be a lot more in the Congo that could never get out of the Congo. So I organized a trip to Kinshasa in September of that year, and took a team there to do that first investigation.
Did you ever cross paths with Peter Piot at that point?
Well, Peter was part of my team.
Oh, he was part of your team?
Yes, yes.
Okay.
Yeah. Peter Piot and Tom Quinn, both were part.
Now, since there was no antibody test in 1983, how were you identifying the HIV patients?
Well, we obviously couldn't identify HIV patients at that time because we didn't have an HIV, we didn't have a virus, so that meant we didn't have any antibody tests. So the standard test that was used was a ratio of particular kinds of lymphocytes, CD4, CD8 lymphocytes. And people had already found that it was abnormal, that it was quite low in these patients with this syndrome. And so we took the materials and technical support with us when we went to the Congo, so that we'd be able to conduct that assay or that test on patients that we suspected to have the acquired immunodeficiency syndrome.
And why was that T4 so important?
Well, nobody knew at that time, except it seemed to be fairly clear that somehow and for some reason these CD4 cells seem to be destroyed by the disease. Now, we understand a lot more today because it's 25 years or more now since we discovered the virus, or about nearly 25 years since we discovered the virus. So we know a lot, we understand a lot more about how that happens. At that time, we just realized that there was clearly what seemed to be a destruction of these CD4 cells. And in fact, the technology to do this was relatively new. The so-called monoclonal antibodies that are used that allow you to distinguish between these lymphocytes, the CD4 and CD8, had only been available for a few years. And so this had been an important breakthrough and allowed that early identification of this defect. And that helped to show and lead the way in understanding what this disease was about.
And what were your findings?
Well, we spent about 6 weeks in the Congo, in Kinshasa. We worked at 2 different hospitals, and we found over 30 patients that fit the clinical syndrome of acquired immunodeficiency syndrome. And all of those people had an abnormal ratio of CD4, CD8. So what we learned from that is that the disease, now remember, it takes some years for the disease to develop into the disease. You start with the infection first, the HIV infection. And the incubation period is fairly long, in a matter of years. So when we found this number of patients just in 2 hospitals, it told us right away that this had been around for a while. This wasn't something brand new that had just started like it had in the United States, where we, in the whole of the United States, we only had a handful of people. So that told us, first of all, it had been around for a while. The second thing we found was that this was heterosexual transmission. And of course, this was big news when we came back to the United States, because to find that the basis of what appeared to be a whole ongoing epidemic in Africa was primarily heterosexual transmission. And the reason we concluded that was because we had a male to female ratio of about 1 to 1. And so our conclusion was this pretty much had to be heterosexual transmission. And of course that was a big surprise, because at that time the male to female ratio in the United States was about 12 to 1.
And how did the Reagan administration respond to this new data?
When we came back, I reported these findings to the director of the Centers for Disease Control, Bill Foege, at the time. And he was so struck by this because of the evidence of heterosexual transmission, and obviously the importance of this given how much we had found. Oh, I should mention one other thing that we found when we were in the Congo, and that is that the risk of this disease was very much tied to the number of sexual partners, very similar to what had already been reported in the United States in the gay community, but we found it in the heterosexual community. And this also suggested, again, a sexually transmitted disease, which everybody, I think, was pretty persuaded that that was the case. However, the ongoing kind of belief, if you will, particularly in the Reagan administration, was this was a gay men's problem, and it wasn't something that you were going to see in the general population. So when we came back and I told Dr. Foege about this finding, he collected a group of people, including Jim Curran and some others, and we got on the telephone. We didn't have video conferencing ability in those days, so we got on the telephone with the Assistant Secretary for Health, and it was a guy named Ed Brandt, and I reported to him what we found. And it was fascinating because his first response was, "I don't believe it." And so I remember the response in the group that I was in was kind of jaws dropping open and saying, "What is there not to believe? Here's the evidence." And so he said, "Well, maybe it's mosquito-borne." And we said, "Well, sir, in the African setting at least, children are bitten far more by mosquitoes than adults. And we don't see that much disease in children. We found a few children, but nothing like what we found in the adult population. And the fact that there was the number of sexual contacts was a clear risk factor also supported this finding. So he still maintained that he didn't believe it. There must be, as he said, another explanation. So the initial response was, and this was already early November, late October of 1983, the response was, "I don't believe it."
Why do you think there was so much resistance from the administration?
You know, I can only believe that they had a political agenda for this, a sort of a moral political agenda, which didn't allow them to look at facts. And I think this tends to be a characteristic that we see in a lot of political people, is don't confuse my political stance with the facts. And that's the only explanation I can, because that I can come up with, because most people who were rational would look at this and say, you know, evidence is pretty clear.
Did you have any problems funding your Kinshasa experiments?
We did not have trouble funding our Kinshasa work. And in fact, it turns out that NIH was also very anxious to play a part in this. And so we ended up setting up really what turned out to be a tripartite setup where the primary epidemiologic work and the overall direction of the program was under the responsibility of the CDC. The laboratory side of it was supported by the National Institute of Health, and they had someone there who ran the laboratory. And then the clinical side of this was supported by the Belgian government. And so there were three groups that collaborated on this early study, and we had it set up. I recruited Jonathan in February of 1984, and Jonathan was on an airplane for his first visit ever to Africa with me in March of 1984. And by the time we got him some training, because he hadn't been working with this disease, he was out there and working by May of 1984. So it was a fairly rapid response, and I think that's an illustration of the fact that CDC did not wait, and they didn't ask for permission from the White House or from the administration to go ahead and set up what clearly was an important response to this early evidence of an epidemic in Africa.
Would you say this is the first time that these interagencies came together with foreign agencies to try and combat an infectious disease?
You know, there probably were some earlier efforts, but it was certainly the first one that I was aware of, and I suspect it was the first one at such a high profile, at such a high level, where they actually put quite a lot of money into it too, because there was no laboratory that you would call a laboratory at the Mamiemo Hospital where we established the program. And in fact, we had to go in and do a lot of renovation of part of the hospital there in order to set up the program.
Can you give me an overall summary of the Kinshasa experiments and what you revealed from those?
Well, what we wanted to understand was how big was the problem in Kinshasa? What were the risk factors? Were there risk factors that we hadn't detected? We saw in that early investigation the presence of number of sexual partners, just like that had been reported by that time in the U.S. As an important risk factor. But we wanted to understand, since this was heterosexual transmission, we needed to understand more about what was the risk of partner-to-partner transmission when one partner had the disease and the other didn't. We wanted to understand how you might prevent that transmission. We wanted to understand what were the dynamics that we would have to understand to have a broader public education and prevention program. We didn't really know what kinds of messages or what kind of educational programs might be required to get started for a prevention program in that part of the world. So the purpose of this was obviously on the one side, was to conduct research to try to better understand the nature of the epidemic and all that, but it was to use that information as a way of better focusing the intervention programs, which the government was anxious to start. There was one interesting aspect about this in the very first investigation. When I had set this up, I did it through the United States Embassy. And initially, it was just the CDC that was going to do this investigation. Later on, I was asked to include people from NIH and from Belgium, and they turned out to be Tom Quinn and Peter Piot. And in setting it up, I had worked through the U.S. Embassy in Kinshasa, and I had a colleague who was in the Ministry of Health in Kinshasa with whom we worked to set all this up. And so we had everything organized to discuss directly with the Minister of Health and with his deputy, who was my friend. His name was Kalisa Ruti, by the way, my friend who was in the Ministry of Health there. And it was very interesting. When we had our first interview before we did the investigation, the Minister of Health told us, look, we have major health problems here. We have malaria, we have diarrhea, we have tuberculosis, we have measles, we have just about everything you could imagine in terms of health problems. And he said, there's no way that we're going to make this any kind of a priority. You're welcome to come and look at it, but don't expect us to make this a priority. At the end of the 6 weeks when we were there, after having done our investigation and presented the data to the Minister of Health, they were so startling to him that one of the first things he did was to set up a major news conference. And we then conducted, in particular Peter Piot and I, because we were both French speakers, were able to participate in directly in that news conference. It was held right there in one of the rooms, large rooms at the Mamiema Hospital, and it was really the first news conference, I would imagine, on the continent where we actually answered questions of reporters and discussed this disease based on what we knew at that time.
And what were those results from that 6-week experiment?
The results were that the Minister of Health, first of all, the result was that we decided we needed a long-term study. The second result was the Minister of Health welcomed that study. And I laid the groundwork for you because initially they said there's no way we're going to be able to make this a priority. When they realized the enormity of this, they immediately said, yes, we would love to have you come and set up a study and work with us to try to understand what's going on. So that was one of the results. A few months later, when I was back up in the northern part of the Congo, I was in a city called Lisala, which is up on the Congo border, the Congo River, and I was staying in a hotel there. And the manager of the hotel came up to me and said, I think I know you. He said, I saw you on this television program about this new disease. So I think that's an interesting illustration. I was far away from Kinshasa, yet over that period of time there was sufficient penetration of the message that this guy was able to come up to me pretty far away and say, you know, I heard about this, I saw you on this television program.
Why in your mind then do you think that, or how I guess, did it break out in homosexual communities in developed countries like the US, Canada, England, Australia, but yet it was primarily focused on the heterosexual populations in Africa?
Well, why did it occur in the homosexual population in the more developed part of the world and the heterosexual population in Africa, I think is an important question. And I think at the bottom of it lies the fact that it's a sexually transmitted disease and that it was related to a large number of sexual partners. At that time in the United States, as you may remember, there were major changes in our behavior in the United States. We were urbanizing very rapidly. Just like urbanization in all parts of the world, people's behavior tends to change when you come from a small community where everybody knows everybody to a large city where people are relatively anonymous. And so I believe what transpired in the developed part of the world, that we saw this transition of people from rural to cities, and along with that changed their behavior. And it so happened that at least in the gay community, there was a great increase in sexual contact. This was a time when they had relative sexual liberty relative to what our society had permitted before. And this resulted in a huge number of contacts, sexual contacts. And when you look back at all those early studies, the big risk factor was the number of different sexual contacts people had had. Now, this is not a judgment on the gay community, it's just the way it was, and that's what we saw. Whereas in Africa, we didn't have that kind of, we were just seeing the real, not the beginning, but the emergence, if you will, of urbanism in Africa. And we were not seeing the major changes, though clearly people changed their behavior there when they went to big cities, just like people all over the world do when they go from a small town to a big city. But we didn't have the homosexual practices in Africa were not nearly as prominent as the heterosexual practices. Whereas in the United States, that was the group that first exhibited the increased number, the markedly increased number of partners in the urban setting, and this is how I think it, in fact I'm sure it's how it got into the gay community in a prominent way early on. Whereas in Africa, when people went to the urban settings, they still, when they changed their behavior, it still was involving heterosexual contact much, much more than homosexual contact. So at the bottom of all this, it was still all sexual contact, but it was different for different reasons, both cultural and political and economic in the developed world versus in Africa.
Do we know how it got from Africa to North America?
Well, I know how I think it got. First of all, I think I know how it emerged in Africa, and I think this is a point that people now are starting to understand. And initially, if you remember, some of the theories to do with how AIDS got started, a lot of it had to do with, well, this must be a mutation. Must be somehow the virus mutated and suddenly it just took off in the population. Well, that never worked. It never worked scientifically, and it didn't work either molecularly, and it didn't work, in my opinion, epidemiologically either, and I'll give you some background. Africa is a continent that up until probably 75 or more years ago was predominantly a hunter-gatherer population. And in Central Africa, where much of this emerged, where you have the rainforest, it was very much a tribal population that were primarily, not totally, hunter-gatherers, and they hunted for their food. We now understand, and this is through the molecular work that's been done in more recent years, that there are a number of viruses that are out there in chimpanzees that are very closely related to the viruses that we see in humans. And people in Africa, in Central Africa, are pretty indiscriminate when it comes to hunting and to their food source. And chimpanzees are a source of food, and they remain so, even today in some of these areas. So they were a source of food, just like antelope or hippopotamus or other, and monkeys. Monkeys are also, continue today, be a source of food for people who are hunter-gatherers in that area. Now, to be sure, the number of hunter-gatherers is decreasing. So what we actually saw over, I'm sure, hundreds or if not thousands of years was the fact that people hunted these chimpanzees. They would kill them. They would chop them up for food to cook. And they would have contact with their blood and their hands. And occasionally you would see transmission. Well, we couldn't see it because we weren't there, but what occurred was occasional transmission from a chimpanzee to a human in the process of contacting the blood. And when that occurred, this person might get infected. Now, probably most of the time, it may not have resulted in an infection, but occasionally it resulted in an infection. And when it did, that person may or may not transmit it to his wives or to perhaps a few other people in the village. Most of the time, the transmission didn't go very far. Now, the evidence for this is the fact that we see something like 30 or 40 different genotypes. That is, they're genetically different, they're related, but genetically different viruses scattered throughout this central part of Africa. We don't see that diversity anywhere else. All of the viruses that occur in all other parts of the world also occur in that area, but there are a number of viruses that don't occur anywhere else except that area. Now, that clearly shows you that this is the area in which it arose. And when you see all these different genotypes in different areas, what you really start to understand is, wow, that occurred because you had a tribe over here and somebody in this village killed a chimpanzee and got infected, and probably did a little bit of transmission and set up a little focus of infection in this area. Another one occurred over here, another one occurred way over there, and these foci were set up over a long period of time. But because the populations were not large and the practices were different in the small towns, just like they are in small towns here in the United States, then you were not going to see the level of transmission that would be required to get to epidemic proportions. But times changed in Africa. In the 40s and 50s, and there are good data to show the urbanization of Africa. People started to move, with the colonization, people started to move to cities, and Africa became more urbanized. People moved from the villages in. A few of those people had HIV, and when they moved in, they changed their behavior. There was more sexual contact, to be sure. And eventually, as we began to have more contact with Africa through airplanes and boats and a lot of other the entry into other parts of the world, pretty inevitable.
In your book, you said that you set up that meeting in the Central Republic. Is that correct?
Mm-hmm.
In Bangui or
Bangui.
Bangui.
Okay.
Bangui. What was the primary purpose of that meeting?
Well, the first AIDS meeting on the continent of Africa that was held by WHO, at least, and I'm not aware of any other meeting, was in 1985 in Bangui. Fakhri Assad asked me to set that meeting up, and I contacted colleagues at the Institut Pasteur in Bangui at the time, because I knew they had a good facility for meeting and for organizing a meeting in those days. And so I worked with them to set up the meeting, and I thought it was a good place to have the international community because it would get the French involved. And the French, through their Instituts Pasteur, had and still have to some degree a very potent program for being able to really launch investigations in many countries on HIV, and they did that to some degree. So anyway, we organized, and Fakhri agreed that we would have the meeting in Bangui. And at that time, Luc Montagnier was involved, and he had already become very well known. So he helped he and his colleagues helped to set up, although he didn't attend the meeting. And we were able to get the international community. Now, there had already been an international meeting on HIV, but it had been held in Europe. And I felt that if we really wanted to have a meeting about AIDS in Africa, it needed to be in Africa. And so that was where we set up the first meeting. And many of the players, even today, who are still involved with HIV, came to that meeting in 1985, and that's where we developed the Bangui criteria for the clinical diagnosis of AIDS. As you might imagine, in those days, working in Africa, we didn't have, even though by 1985 there was a serologic test, you could do antibody tests and make a serologic diagnosis for exposure. Most of Africa didn't have access to this. This was new, and they didn't have access to it. So how are we going to count cases? What were the criteria? And one of the things that we did in that meeting was to sit down and hash out the so-called Bangui criteria for the diagnosis of AIDS in Africa. And that's been used for literally since then as a set of criteria, clinical criteria for being able to diagnose AIDS. And that helped in the overall effort to count cases, because we needed to know what was the impact of the epidemic. So one of the things that came out of that, in addition to some collaborations and other things that happened, were these clinical criteria for the diagnosis of AIDS.
Yeah, I noticed in your book you said that was your main point, to come up with that clinical criteria.
Right. Mm-hmm.
Can you just briefly explain how does the Bangui definition work? Like how is it applied in terms of medicine?
Well, it's set up so that weight loss, and I must tell you, it's been over 20 years, and I probably can't cite every single one of the criteria, but the idea was to say, what would be a simple way for a clinician to look at a patient and be reasonably sure that they have AIDS? And one of them clearly was prolonged weight loss, an opportunistic, some kind of, and for there it was either TB or a fungus infection that was going to be obvious, that didn't require a laboratory to investigate it. And there probably were a couple of other criteria that were perhaps a little bit more minor that were involved. But the purpose of it, the principle was, how can you provide simple clinical criteria that you don't need a laboratory, you don't need a microscope, you don't need that a doctor can look at a patient and say that this patient likely has AIDS. And that was the purpose of it. And among the major criteria were it was a severe weight loss and a evidence of some kind of opportunistic infection, fungus infection of the mouth, for example, or TB. Those were the major criteria for AIDS.
Now, was it the technology was new, or the blood tests were just too expensive for African?
Well, the technology was new, and it hadn't even really been developed commercially. There were only a few places that made a little bit of material, so it hadn't been developed commercially, which means it was very expensive, and it simply, just the fact that it was not available meant it was very expensive, and there were no facilities, and I mean you have to have a certain facility to be able to put the instrument, and you have to have technical people who can run the instrument to do the test. Nowadays we have dipsticks and many things, but at that time it had to be a machine, and we had to run a test in a certain way, and it was quite tricky actually. And there were some big mistakes made in the early days of testing for AIDS because people didn't understand the limitations of the test. So it was a fairly tricky test to do. And for all those reasons, it really wasn't feasible to get it started right away. And yet we needed criteria that were immediately available to clinicians and for public health people to be able to get some estimate of the number of cases they were seeing.
What kind of big mistakes were made in early testing?
Well, this gets very technical, but the mistakes that were made is that people thought you could do the test with a single sort of control, that is, a negative control, when in fact what you really had to do was to use each person's serum in Africa. Now this worked well, you didn't need all these controls in other parts of the country, in other parts of the globe, but in Africa, probably because people are exposed to so many parasites and so many different infections, they tend to have a lot of background in their serum that made this test falsely positive. And so there were some instances where people found, for example, there was one study where people examined blood from a group of children in the Congo and found 60% of them had antibodies to AIDS. This was actually published. And it was because they didn't understand the limits of the test, and they hadn't used the proper controls, and so they way overestimated, and there were some other papers like that, and they had to be withdrawn eventually. But you can see that it created a lot of confusion because of that.
I'm sorry, what do you mean by estimates? I don't know. You said that the children, you mean estimating prevalence for the
Yes,
country?
yes. I mean, if you come in and say 60% of the children in this test were positive for HIV, I mean, that's a staggering number. We don't even have today any places with that high number. And so you can see, I mean, if somebody says to you 60% of the kids in the eastern part of the Congo are infected with AIDS, because that's what the antibody tests that they did said, I mean, you can imagine that would be pretty startling.
What exactly is epidemiology for people that don't understand?
Epidemiology is simply the study of the distribution of diseases in populations. So you're just looking, and that's what we usually call it, prevalence or incidence, but we ask ourselves, how many people have this disease? And who are they? And where are they? And that's what epidemiology does.
And one of the things you said was in 1985 there was a need to estimate the size of this epidemic, and this required surveillance. Can you tell me what that means?
One of the ways that you estimate the size of a problem is through what we call surveillance in epidemiology, and that means you set up a system, to put it simply, to count cases.
Oh.
And so in this country we count AIDS cases. We report them and count them. That's surveillance, and that's what we want to be able to do in Africa. Why do you want to be able to do that? Because that's the way you allocate resources, that's the way you plan for how you're going to target your messages, and part of surveillance is understanding who are the biggest risk, who are the people at biggest risk. In the early days of the epidemic, it was in the United States, it was the gay community. In Africa, it was the heterosexual community in big cities. So this kind of surveillance and the epidemiology, that's what you use in order to show you where your target messages and your prevention programs need to be focused.
So once you guys came up with your definition, was there a good mobilization of clinicians to go out and start trying to find all these cases and identify them?
You know, the translation of a method of surveillance to actual surveillance takes a long time. Imagine, you can't just go out and suddenly, even in this country, trying to get clinicians on board and teaching them the methods for diagnosing something that's new. It takes a long time. In Africa, there are few physicians, very few relative to the population, in the most part. Getting them trained, getting them to be setting up, there was no system of surveillance for the most part, no reporting system like we have. So none of that was available. It means what we had to do, rather than to rely on a lot of physicians out there to report cases like we do in the United States, we had to go out and do surveys. So we'd go out and do a survey of a segment of the population. And we do it in a random survey, and then that would allow us to take a statistical sample, and then from that we would estimate the overall prevalence of AIDS. And many parts of Africa, that's still the way it happens.
At what point were you able to learn the status of the epidemic? You know, once you came up with the ability to do surveillance, at what point did you realize where the epidemic was in Africa?
Well, again, the effort to go from where we started, which is in Congo, and then to expand that to other countries and start to understand what was going on in other countries, took a lot of time. I mean, that was one of the first efforts that WHO set up, was to do an assessment in each country. And that meant you had to go in with some forms that you would go out and fill out, survey forms. You'd go out and do a survey, and you'd bring people in, and you'd hire a group of people, train them, and then set up to do the survey out in some population, often in big cities in various countries, in order to estimate what was the prevalence both of AIDS, the disease, and later when we could do more testing of HIV itself. So the ways that we had of estimating this were to do these surveys, because there was no way we were going to set up countrywide surveillance throughout Africa. I mean, that was just not going to happen. So we had to do it through these surveys, and so the WHO set up to start this series of surveys, and what they did was to set up a short-term and a process for having a short-term plan and a long-term plan. So the short-term plan was like 1 or 2 years, then a longer-term plan was for 5 years. And the short-term plan was to set up methods of measuring the size of the problem and estimating who was at biggest risk. The longer-term plan had to do with preparation of messages and starting an education program that would help in the effort for prevention.
More and more antiretrovirals are finding their way to Africa today. Before PEPFAR, though, and other global fund programs, how were patients in the Third World treated when they were diagnosed with AIDS?
The early efforts at treating AIDS in Africa were very, very limited. And the reason is because, first of all, of course, we had no drugs anywhere to treat AIDS itself. And secondly, while we could treat the opportunistic infections and these problems that arose in the developed world, often in AIDS patients in Africa, they didn't even have access to medical care to treat their opportunistic infections. That is, the infections that were treatable, tuberculosis, certain fungal diseases, other infections that were actually treatable. We didn't even, often they didn't even have a way to diagnose them, much less treat them. So I must tell you that for the most part, people were simply, I mean, you would do as much as you could, but for the most part, people just were left to die.
Do you have any comment on the black market where people market AIDS medication? So it's usually like an aspirin, particularly some kind of other narcotics.
One of the big problems in Africa is fake medicine and putting these things on the market, the black market, as you indicated, for medications. When I was doing an investigation of Lassa fever in Nigeria back in the late 80s, one of the things that we came across was this pink syrup that was supposed to be the medication for malaria for children. And it turns out that a lot of the medication that was put on the market was just pink sugar water, and there was nothing in it, and yet it was being marketed to treat malaria. And this is a constant problem in any country where you don't have tight control over drugs and their use in the population. And Africa is a continent where there's almost no control. So the black market, where people can peddle anything that's milky water, anything as treatment, is a dangerous situation. And I'm afraid that's a big problem in a population where people are not well educated and don't really understand the nature of drugs and the importance of having the right drug that's a good quality. So this is a big issue that countries are going to have to deal with, and I think the WHO, I'm sure WHO understands this problem. It's one thing to understand it, it's another thing to have an effective approach to trying to do something about it. And it's difficult for WHO as an organization to do something about it. It's really something that has to be done at the level of African countries. You know, it would probably be a toss-up between Sierra Leone and Liberia because of the wars there. Mm-hmm. With Malawi probably, you know, pretty close on their heels. And Zimbabwe, believe it or not, is headed that way.
Well, I see the inflation in Zimbabwe.
Yeah, I mean, Zimbabwe is just a basket case for economically.
So I assume that all those countries, they can't afford testing then, and they use the bank.
Not unless WHO gives it to them and helps them set it up, and even then, so many of the facilities were destroyed. I mean, in Liberia, the last time I was in Liberia, there was almost nothing left. We traveled all the way up to the border, and there was almost nothing left. So,
because of the monetary constraints that still definitely plague Africa, is the Bangui sorry, tell me one more time. Did I pronounce it right?
Bangui.
Okay. Is the Bangui definition still used today?
You know, I haven't followed the use of the Bangui definition in recent times, but I'm fairly certain that in many parts of Africa where there's still little or no testing available, that definition is still used, and I wouldn't be surprised that it's used in the poorer parts of Asia, where again resource constraints wouldn't provide the facilities for testing.
One of the reasons I asked was I interviewed a few clinicians in South African hospitals, and they said they actually ran rapid tests on some of their patients that were diagnosed with Bangui, and a couple turned out to be actually negative.
Right.
So they said it's important to
absolutely.
To do that confirmatory
absolutely
test.
You always must do a test and a confirmatory test, because, you know, first of all, the Bangui, that's a clinical definition. That's not, people could have TB and not have HIV and fulfill the Bangui criteria. They'd lose weight, they'd have TB, and they could look like they have AIDS when they don't. So you don't want to start giving these potent medications unless you're sure somebody's got AIDS. So I'm absolutely sure that anybody who gets started would have to take a test and then have a confirmatory test.
Some people are very fortunate that they don't have these side effects. So